try to understand the whole heme and onco, right? So after this video you will have a very good idea about how to think when it comes to questions, when it comes to patients, in terms of heme and oncology, right? So there are 7 type of kingdoms right here, right? We have problems in RBCs, we have problems in WBCs, we have platelet problems, we have coagulation problems, we have hemolysis, the blood is breaking, we have marrow proliferative disorders, and we have hematological malignancies, right? We have 7 problems, right? So patient presentation, that can be 2 type. First is cell line problems, right? And second is that let's try to understand if maybe this patient has too many or too few cells, right? Maybe the lineage is messed up. Which one? Maybe RBC is messed up, WBC is messed up, platelets are messed up, or maybe all of them are messed up, right? Or we can ask the patient, is it a production problem or a destruction problem, right? And then we have these clues, morphological clues, right? We have MCV, we have smears, right? Like schistocytes, target cells, etc., etc. And then we have the lab, PT, PTT, PLT, platelets, retics, right? LDH. And then we can always think, what's the etiology? Is it inherited? Is it drug induced? Is it some sort of malignancy? Is it autoimmune, right? So we can have some idea, right? So this is a universal plan. This is a universal question that we can, ask the patient, or maybe look at the question in this way. So the first thing that we should really ask or look at the patient is, what kind of cell line is messed up? Now, we have 3 ways we can, we have 3 lines going out here. Let's go by one. Let's go on to the left one first, right? So here we have cell line problem. What kind of cell line problem? Maybe there are too many cells. We have cytopenia. Now, which cytopenia are we talking about? Maybe we have cytopenia of isolated, means just platelets, or maybe just WBCs or just RBCs, or maybe we have pancytopenia, everything is down, right? So one line cytopenia or pancytopenia, everything is down, or just one germ line is down. If it's pancytopenia, we want to think about marrow problems, we want to think about aplastic anemia, we want to think about Fanconi syndrome, right? Just look at these words, thumb anomalies, right? These are super high yield buzzwords. We have Fanconi syndrome, very rare. We have viruses that can induce pancytopenia. We have chemo that can induce. We have PNH, right? The CD55. I hope you remember. I hope I remember, not you. And then we have hairy cell. Then we have MF, right? So we have this production versus destruction. So we wanna think, is the production is too low? Is the production getting messed up? Or is the destruction high, too high? What kind of pancytopenia is that, right? Now, if it's some sort of isolated cytopenia, we want to think about it, neutropenia. What kind of neutropenia is that? Do we have neutropenia and fever? If we have this fever, it's a medical emergency. We want to give them broad spectrum antibiotics, right? Then we want to think about the cause of this this neutropenia. So whenever we have a patient or a question in which we have neutropenia, the first thing we want to do is broad spectrum antibiotics. Then we can start thinking about drugs. Why he has neutropenia? Maybe he took a lot of clozapine, maybe it's a PTU, maybe he took this TMP-SMX, right? Maybe it's a chemo, maybe it's cyclic, maybe it's viral. Which kind of neutropenia is that? Now we undergo more, and then we are thinking, we covered neutropenia, we covered pancytopenia, what about RBCs? Well, here we have RBCs. Now this is an anemia algorithm, right? Now here we want to think about the MCV first, right? MCV is this size of the RBCs, right? We can have smaller size, we can have big size, we can have normal size, right? Let's talk about small size. If we have small size, we want to think about iron deficiency, we want to think about thalassemia, right? Because we see these target cells, right? How we see the target cells? They look like that. Now we have this problem, right? we have iron deficiency, thalassemia, sideroblastic, problem in carrying iron, anemia of chronic disease, TBC goes down because liver is cooked, inflammation has cooked the liver, and now we cannot make transferritin, right? Not transferritin. We just TIBC goes down. It goes down because TIBC mostly reflects the transferrin levels, right? This is transferrin is this protein that is made by our liver to carry the iron, right? So in this chronic inflammation, maybe CKD, maybe some sort of cancer, right? These chronic inflammation, they release something called as interleukin 6. Now when we have this interleukin 6, we increase the production of hepcidin, right? So hepcidin goes up, tries to find iron, right? And now actually hepcidin actually blocks what? Blocks ferroportin. Now once the ferroportin are blocked, right? Once they block the ferroportin, all the iron is blocked inside of a macrophage, right? So iron gets trapped inside the macrophage, inside the liver cells, inside the enterocytes. So less iron gets released in the blood, less serum iron, right? Now at the same time, during inflammation, liver makes these acute phase reactions called CRP, ferritin, fibrinogen. They all shoot up, right? So liver makes less transferrin. That is important because transferrin is a negative acute phase reactant. So less transferrin equals to less TIBC, total iron binding capacity, because transferrin is the iron binding capacity. Okay, I'm not going to go much into them. So anemia of chronic disease we can have in microcytic anemia. Okay, we have lead poisoning, also microcytic anemia. So iron deficiency, thalassemia, iron sideroblastic anemia of chronic disease, lead poisoning. We are thinking about iron here. The most overall idea is about iron. Okay, now when we think about macrocytic, the big one, we have some sort of problem in synthesis of the RBCs, right? Macrocyte over. What about the normal value? The normal value of MCV is around 90 femtoliter, right? So if it's more than 90, if it's 100, it's big. Why it's big? Before asking this question, we want to know if the neutrophils are hypersegmented or not. Now hypersegmented means if they're mature or immature. Simple question, right? So immature is hypersegmented and mature are not hypersegmented. Okay, simply not hypersegmented. Okay, so mature means the neutrophil cell line is okay. Immature neutrophil means hypersegmented, right? So we have hypersegmented. What? We have megaloblastic anemia, B12, and folate deficiency, right? Okay, so whenever we have megaloblastic anemia, the first sign of megaloblastic should be neutrophils, not the MCV of RBCs. That's important to know. Second thing is that the neutrophils are not hypersegmented. What can it be? Okay, neutrophils are not segmented. It means the cell line, the immature, the synthesis is kind of okay. Then what is messing up with our synthesis of RBCs? Alcohol. Alcohol actually cooks your manufacturing, or your marrow. Actually it cooks it. Like you cannot just produce good RBCs. So we have alcohol, we have liver, we have drugs, and then we have MDS, right? Most of you must be wondering, what the hell is this MDS? It is myelodysplastic. Wow, weird. I think I just want to say myelodysplastic syndrome, right? Now we see MCV goes up, right? But not due to B12 or B9, okay? Now MDS, what is exactly is MDS? MDS is a clone stem cell problem, right? Now problem here is that bone marrow stem cell, they have these mutation and they produce these weird abnormal blood precursors. Now this hematopoiesis becomes messed up, not so good, ineffective, right? You will hear this word ineffective in a lot of question banks. So ineffective. So what really happens is that marrow becomes hyper cellular, trying really hard because cells are messed up, cells are defective, cells are dying early. So we have this anemia where MCV is high, we have neutropenia, and we have thrombocytopenia, right? Or any combination. We have just cytopenias, okay? That's important. We have cytopenia in this MDS as well, okay? So that's why MDS is sometimes called pre leukemia state, basically, okay? Or it can go to acute myeloid leukemia, AML, right? We have 4 type of these leukemia, right? We have ALL, CLL, AML, CML. CML. Under AML we have this AML3, AML-M3, also called APL, right? That's we are talking about APL, that is pre. Do you understand me, right? So just know that high MCV is not equals to megaloblastic. We have megaloblastic and non-megaloblastic. Non-megaloblastic is just we have alcohol, liver problems, drugs, and MDS. Okay, so we have this. So that's macrocytosis. Then we have normal cytosis. RBCs are around 90 femtoliter right here. What the hell? Then we want to think about reticulocytes. Now, if reticulocytes are high, it means things are not going well. It means we have hemolysis. Blood is being messed up somewhere. Blood is being destroyed somewhere, right? That's why we have retic high. Marrow is pushing the reticulocytes, right? So destruction, hemolysis, go to the hemolysis algorithm right now, we will. And if the retic is down, it means bone marrow is shutting down, means marrow problem. So we can kind of say that the retic is a good sign of marrow, right? When I want to think about marrow, I want to look at retic sign, okay? When I want to think about megaloblastic, non-megaloblastic, I want to look at neutrophils, right? If they are hypersegmented, if they are immature, megaloblastic. They are not immature, they are mature, it means it's a non-megaloblastic. Okay, that's a good sign to think. That's a good way to think, right? In microcytic, I want to think about iron deficiency. In what kind of iron? How can iron be messed up? In many ways. Iron deficiency, the patient is not taking enough iron. We have thalassemia, right? We have target cells, beta thalassemia, blah, blah. We have sideroblastic, right, rings. Then we have anemia of chronic disease, iron is locked in. And then we have lead poisoning that leads to the ferrochilase inhibition, right? So that is anemia algorithm, right? That's the whole anemia. So we just completed cytopenia if we have 2 less cells. Now we ask the question again, which cell line is messed up? What is it? Is it go down or is it up? So the second question we want to ask is, cells are up, everything is up. Proliferation, what can we think about proliferation? They are going up. Okay, let's ask a bunch of questions. What can we ask? Proliferation, too many cells. Now, first question, which lineage? RBCs are high, or WBCs are high, or platelets are high? What kind of cells are high right now? Not high. Sounds like they are doing drugs, but they are not. RBCs are high here. We have high RBCs. How? We have polycythemia. Well, gotta check the EPO. If the EPO is low, what does it mean to you? EPO comes from kidney. So if EPO is low, it means kidney is not sending EPO. If kidney is not sending EPO, then who is sending EPO? Maybe someone in sports is sending EPO to the body. Low EPO. Primary marrow problem. We have JAK2 mutation, right? Bolivera, weird name. PV. Polycythemia vera, JAK2 mutation. We have low EPO, but still the RBCs are up, right? Because we have a cancer, we have a problem, we have a mutation that is producing its own EPO. All right, so we have pan-myelinosis, right? We have all of them are up, right? All of them. We have hyperviscosity syndrome, symptom, thrombosis symptom, and acute treatment, we have phlebotomy, just remove it, and chronic, we can use hydroxyurea, okay? Now you must be thinking, he says phlebotomy, phlebotomy, whatever. phlebotomy or hydroxyurea. Now, how they work? That's a good question, right? So when we talk about polycythemia vera, right? Polycythemia is just RBCs are up, WBCs are up, and platelets are up, right? Pan-myelinosis, right? Everything is up. Now, this causes like thrombosis, right? Stroke, DVT, because if we have less blood, the blood moves well. If we have a lot of blood, then the speed of the velocity of the blood actually quite slows down because we have more blood inside, so the blood moves slowly. That actually contributes to the blood having more thrombosis, like DVT and stroke, right? And we can have headache because blood is not moving. Again, simple, right? Now, why exactly we have thrombosis? Because it's just not the thick blood, okay? We have three things going on. We have hematocrit that increases, right? Hematocrit increase means percentage, right? So blood viscosity goes up. We have sluggish blood. Then we have platelet increase. Now, what's going to happen if we have platelet? If we have a lot of platelets, they're going to clot because platelet clots, right? And then we have these WBCs called leukocytes, right? And then they activate the endothelium, right? Once they activate the endothelium, right, leukocyte endothelium activation happens, and then we have a lot of thrombosis, right? So polycythemia vera is just basically a clot making factor. That's it. Now, how exactly phlebotomy works is that phlebotomy removes the blood on a cyclic way. Periodically, it removes it. It directly, it's like bleeding. You're bleeding, okay? It directly reduces the RBC mass. It lowers the hematocrit. Less RBCs equals to less viscosity equals to less thrombosis, right? Again, in polycythemia vera, we want to have less than 45% hematocrit, okay? So that's something we want to know. Hydroxyurea, how does it work? Hydroxyurea stops something called as ribonucleotide reductase. Now, I just remember that. Yes, I have memorized that ribonucleotide reductase. It stops DNA synthesis, right? Once we stop the DNA synthesis, we will, of course, have less RBCs, less platelet, less WBCs, right? This is helpful if the polycythemia vera is a marrow overproduction syndrome, okay? Especially in patients who are older. We have some thrombosis complaints, right? So great, hydroxyurea is great for myeloproliferation, right? Great for this pan-myelinosis. So we have low EPO. It means someone else is giving EPO. Maybe cancer is giving the EPO. Then we have high EPO. Why we have high EPO? Kidney makes EPO, right? So we have secondary EPO, right? Kidney makes EPO. Why we have high EPO here? Because hypoxia. We are not breathing enough. COPD, apnea, altitude problems, low CO2, kidney, give EPO. Simple stuff. Then we have ectopic EPO cancer, such as renal cells carcinoma, hepatoma, right? And then we have exogenous EPO, right? We are giving exogenously EPO. Someone else is giving doping, right? Isolated RBCs, right? Simple stuff. Okay, so high EPO versus low EPO. Polycythemia is primary, secondary. You must think, primary should be high EPO, but it's actually opposite. The primary has low EPO and the secondary has high EPO. Okay, so RBC is high. We get it. WBC is high. Why? Why WBC is high? Is it is it reactive reaction or is it malignant reaction? If it's reactive, then we have a leukemoid reaction, right? In leukemoid, we have less LAP, right? Sorry, high LAP. Alkaline phosphate, right? So we have high LAP. Let me just open up that LAP. Where are you, my LAP? Did I write it? I think I forgot. But okay, nevertheless, we understand that LAP. Where are you, LAP? Yes, here we are. So we have reactive versus malignant, right? Reactive is just we have some sort of infection, some drug, some viral that has caused our system to push WBCs out of a marrow. What can I say? Marrow reserve into the active line, right? And it's done via cytokines, by the way. So that is reactive. Now it's usually more than 30,000, okay? And we have some sort of infection, mainly, I don't remember what was the name of that infection. I remember it started with CLO, I don't know. So I'm not a teacher, I'm just a student, just learning. So I can have some sort of memory problems, yes. So we have malignant WBCs, we have very high low LAP, and BCR-ABL mutation, we have CML, right? So CML, we have four, we have ALL, we have CLL, we have AML, we have CML. Right in CML, we have low LAP, plus we have a soup of these promyelocytes, myelocytes, blasts, everything is up, right? So everything is up, very high, low LAP, and we have CML. If just the blasts are like more than 90%, we can say acute leukemia, right? So we have, again, I'm going to say ALL, we have this more than 90%. Oh shit, we have leukemia. Cool. We have platelets that are high. If the platelets are super duper high, we can have reactive. Why reactive? Because it's reacting to the iron deficiency, it's reacting to the inflammation, reacting to the splenectomy. We have clonal, we have cancer. Clonal means just clones of platelets. So clonal, weird name. Clonal, we have cancer, essential thrombocythemia. Now, under this JAK2 mutation, right? Now, this JAK2 mutation actually leads to fibroblast, right? I'm going to write it here. Fibroblast. Now, what is this fibroblast going to do? It's going to hit a lot of collagen. We're going to have a lot of collagen where? We're going to have a lot of collagen in the marrow. What we're going to get? Dry tap. Marrow is dry, right? So, dry tap marrow, we have, we cannot make blood from marrow. What's going to happen next? We're going to have peripheral hematopoiesis. Where? In spleen, right? So splenomegaly, right? So we have splenomegaly, and if we have this JAK2 mutation again, now this JAK2 mutation actually communicates well to the essential thrombocytosis, right? Thrombocythemia. So what the hell is this? Essential thrombocytosis, actually, we don't have any sort of trigger for it. It's essential, it's happening on its own, right? So we don't have any trigger, right? And our platelets go platelets go more than 1 million. That's essential thrombocytosis. And very important thing, we have symptoms here. In reactive thrombocytosis, we don't have any symptom. That's important. This symptom is called something called as erythromyalgia. We have pain in fingers, right? We have microthrombi, viscosity problems, right? So what can we do? We can just remove the platelet phoresis, right? And we bleed as well because the platelets are more than von Willebrand factor, right? The ratio gets fucked up. So we have bleeding. So that's reactive versus clonal, right? So if our platelets are messed up, we can have this kind of diseases. Okay, what else? So we're gonna ask again, what's the problem? If the problem is some sort of dysfunctional coagulation, platelets, or hemolysis. Okay, so we are under the roof of coagulation, hemolysis. So is it bleeding? Is it clotting? Is it hemolysis? What kind of? Let's talk about clotting first. A lot of clotting happens. Why, I wonder? We can ask, is it inherited or acquired? Or do we need anticoagulant? Yes, we need anticoagulants. First, let's answer, is it inherited or acquired? If it's inherited, usually factor V hidden problems, protein C or S deficiency, or antithrombin 3 deficiency. Not gonna go into them. This discussion will go quite up. Acquired, we can have some sort of APS, antiphospholipid syndrome, SLE secondary to SLE, right? SEE, why did I write SLE? Sorry. So SLE leads to APS, and APS, what is APS? Antiphospholipid syndrome. Now, antiphospholipid syndrome until proven otherwise, APS causes miscarriage. Always remember that. Okay, we're gonna give what? We're gonna give anticoagulant, not clotlet, anticoagulation. We're gonna give them. Why? Because my person is making a lot of thrombosis, a lot of clotting is messed up, right? So we're gonna make a lot of thrombosis. Why? Because we have less this. Okay, so what we are gonna do? We're gonna give anticoagulation, right? So in pregnant women, we're gonna give heparin because warfarin is tetranogenic. We're gonna give in renal failure. We're gonna give unfractional heparin. Great. In normal kidney, we can give low molecular weight. And in HIT, that is heparin-induced thrombocytopenia, weird name. So HIT, HIP, what's really happening here? We have antibodies against heparin actually itself. So we have PF4 complexes, and these platelets get activated. Then we have once platelet get activated, we have clotting. When clotting happen, we have less platelets because platelets are getting consumed by the clotting, and then we have increased thrombosis. Okay, so that is hypercoagulation right there. What else can happen? Patient, we need to, what can I say more about HIT? I think I just remember that for a moment. Yeah. So let's talk about low molecular weight heparin. So low molecular weight, it actually stops what? It actually stops factor 10A. Now factor 10A is kind of important. Stops. So okay, let me talk basically. So we have two factors. We have two important factors, right? We have factor. Okay, let me write it here. Factor 2A and factor 10A. Right? Now remember that factor 10A actually activates factor 2A, and factor 2A makes fibrin. That is important for the crossing fibrin. We need fibrin for the reaction of fibrinogen into fibrin, right? So these are monster coagulation, right? These are like big things in coagulation. So we can stop them by antithrombin, right? Antithrombin 3. So if we don't have antithrombin 3, they're gonna go up, right? Or we can give drugs. So this low molecular weight actually stops the factor 10A, right? And this unfractioned heparin, right, it stops the factor 2A. Okay, so we usually give IV unfractioned heparin because it works fast. And remember that IV actually unfractioned heparin works via liver. So if we have some sort of patient who is liver compromised, don't want to give them. And it's good in renal failure because it doesn't get through the renal get secreted very well, because liver is actually metabolizing this unfractioned heparin. But in the moment of low molecular weight heparin, we don't want to give this in renal failure patient because it's really danger, and it doesn't get metabolized by liver really fast, and then we have this low molecular weight heparin going through the liver, going through the kidney, and it's danger because it's really small and it gets through, and then we have some sort of renal failure. Okay, so other thing that low molecular weight heparin we give subcutaneously because why? Because usually it's given for this thrombophlebitis, superficial thrombophlebitis, done via, I don't know, it's in surgery. I remember that. I don't know why I remember that. And it's really good at, we give it subcutaneously because we want to keep a good kinetic, right? Stable kinetic, that's why. And by the way, low molecular weight heparin has poor reversal. Okay, that's also true. So that is clotting problems. So, okay, clotting is done. What else can we think? We have hemolysis. What kind of hemolysis? We have intravascular or extravascular, right? So again, if we have extravascular, it means where it's getting messed up. It's getting messed up in spleen. Who is killing the blood? Macrophages eating up, right? So all the heme that comes out of this RBC when macrophage bites the cell, it is taken care by the macrophages then and there in the spleen. So we have no spilling of heme inside the serum. That's important to know because that's how you differentiate, right? So hemolysis algorithm, we have increased LDH. LDH are these basically RBCs are packed with LDH. Whenever RBCs die, we have spillage of LDH inside the serum, and then we can check if it's intravascular or extravascular. We have indirect bilirubin and then we have reticulocytes. Retic is going up because we have it's a response from marrow basically. Okay, so indirect bilirubin because RBCs are carrying, right, they are made up of heme breaks down bilirubin, we get, if this bilirubin goes to liver, we get conjugated. If unconjugated, we call it indirect. Cool system name, right? So we have intravascular hemolysis, extravascular hemolysis. Intravascular, we have low haptoglobin because haptoglobin are actually the protein that kind of carries and catches the free heme, because free heme is super duper toxic to you. So we have hemoglobinuria because heme is getting spilled inside the serum, right? So may have schistocytes. What is schistocyte? We're gonna know. Not right now, we're gonna know because we have this. Here we have this smear branch, right? I'm gonna say schistocyte. Basically, schistocyte are just these these mechanically sheared RBCs, right? In case of TTP, HUS, DIC. DIC, we have Adams, bad Adam S13, right? Adam 13 work is to cut on VWF, von Willebrand factor. If it's bad, we have increased adhesion, we have increased platelet formation. It will increase, not platelet formation, increase clumping of the platelets. Once we have increased clumping, the RBCs going across these clumping get mechanically sheared, and we have these schistocytes. So right, in all three diseases and on prosthetic valve, the mechanism is kind of same. On prosthetic valve is just that this iron, or this, I don't know what the material of the prosthetic valve is, this RBCs get mechanically sheared by the prosthetic valve. That's it, right? So if we can repair the valve, we can have a lot of good prognosis, right? So that is schistocyte. I don't know why didn't I go there. Okay, we come back to the intravascular hemolysis. Intravascular hemolysis, RBC getting messed up in the blood. We have increased hemoglobinuria because heme is getting spilled inside the serum. We have low haptoglobin because haptoglobin goes and it just finds all the heme because heme is super toxic. We have schistocyte. We have G6PD, PNH, DIC, TTP, HUS, prosthetic valve. All they lead to bleeding intravascularly, right? G6PD. What is G6PD? What is G6PD? G6PD and pyruvate kinase deficiency actually kind of work together, right? So hemolysis happening intravascularly. So G6PD, I'm gonna say a little bit about G6PD. X-linked, first of all, so only in women, but can be seen in women if we have skewed X. I just remember that, and yes, I memorized that. And we have X-linked and test. It's only we can test G6PD on boys because it's X-linked. And fava beans, drugs like primaquine, right? Sulfur drugs, dapsone. So we have these PTSF. We have primaquine, we have dapsone, we have sulfur drugs, and we have fava beans. All of them, they lead to G6PD deficiency. Well, not G6PD deficiency. Basically, G6PD actually is responsible for reducing glutathione. Now, glutathione is responsible for protecting your RBCs from oxidative stress. From what? From the oxygen that the RBC is carrying, right? So when we carry the oxygen, usually we have oxidative stress. So oxidative stress goes up. If we have G6PD deficiency, we will have less NADPH, right? NADPH, right? So if we have less NADPH, we have less reduced glutathione, less protection from this oxidative stress. The RBC is gonna get boop, and then we have intravascular hemolysis. Okay, so G6PD, PNH. We have problem in we have CD55 and I think CD59 maybe. So we have absence of these markers. Once these markers are absent, the MAC, right, complement MAC, okay, the complement MAC gets activated and thinks, maybe this is anemia, or actually they are kind of inhibition on MAC, right? So once we remove the inhibition, the MAC gets super active and the MAC actually goes and destroys the RBC, and then we have intravascular hemolysis. So that's how PNH works. That's how G6PD works. That's how DIC works. How DIC working? We have problems. With what? We have problems with clot. Why? Okay, so DIC, disseminated, okay, coagulation. Why we have this? So it's just, wow, what happened? Okay, it's glitching right there. Where were we? We are at DIC. Where are you, DIC? IHA, not IHA. Unfraction heparin, APS. PTT is high. We have, where are you? Yeah, DIC, G6PD deficiency, smear branch. Yeah, here we are. Yeah, DIC. Okay, so intravascular hemolysis, DIC. What's gonna happen here? We have DIC. It's just disseminated intravascular coagulation. We have coagulation going on, right? What really here is that we have a lot of coagulation. We have too much clotting going on first, and then once the platelets are kind of dried up, once the platelets are being consumed, then we have a lot of bleeding. Simple stuff. Okay, so anything can trigger DIC. Sepsis, right? We have this any sort of obstetric problems like placental abruption, maybe some sort of embolism from amniotic fluid, trauma, burn, I don't know, malignancy, snake bites, also cause DIC. And what really happens is that we have a massive tissue factor activation. Once we have that, the tissue factors, they start, and then which one? The factor 7. Okay, so tissue factor gets activated, extrinsic ones, right? So 3 tissue factor goes to 7, goes to 10, goes to 5, 2, right? Simple. So thrombin generates so factor X activates the thrombin goes up, and thrombin is the main culprit here. So we have widespread of fibrin clot, right? So fibrinogen converts into fibrin, and now we have microthrombi from all the small vessels: kidney, lungs, brain, skin, liver, all of them, everywhere we have tiny clots. So we have organ ischemia, we'll have organ dysfunction, we'll have renal failure, we'll have respiratory failure, we'll have altered mental status, right? What's going to happen to the platelets? Everything is going to go down. Platelet, fibrinogen, factor 5, factor 7, other thing, everything is going to get consumed. So we call it consumptive coagulopathy. Now we'll have less platelet, less fibrinogen, less increased PTT, because everything is up, and these clots are going to get destroyed. And then once this destruction happens, we have increased D-dimer. That is very important. Who destroys this? Plasmin. So plasmin goes and eats up the fibrin. The fibrin gets, this creates fibrin degradation product, goes up, and this degradation product increases D-dimer. That's DIC for you. Wow, it's like a wrap, I know. So TTP, HUS, prosthetic valve, done. Okay, extravascular. Extravascular, getting spleen destruction, hemoglobinuria, because macro, these big monocytes, these macrophages are eating up, and we think, hereditary spherocytosis. So this sphere getting eaten up, getting bitten by this. So once the macrophage we have this Heinz body, and then we have bite cells. So Heinz body is just simple. Then they get bitten by the macrophage, we call them bite cells. So bite cells and Heinz both are seen in spherocytosis. Warm IHA. Why it's warm? Because it's in your chest. We have IgG. Then we have cold IHA. What is cold? We have IgM. Don't want to think about it right now. So extravascular hemolysis, bleeding inside the spleen. Simple stuff. We don't have heme spillage there. Important to know. Okay, smear. If we're gonna see spherocytes, what is it? If we're gonna say spherocytosis or IHA, what is it? If it's IHA, autoimmune hemolytic anemia, right? We have COMB positive or COMB negative. COMB just tests for immunoglobulin G. And we have COMB positive, warm. We have COMB negative, we have hereditary spherocytosis, because we don't have any immunoglobulin attacking the RBC. Here we have immunoglobulin attaching to the RBC, and then the macrophage, you have IgG gonna eat you up. That's what happens in COMB test positive. That's what happens in this warm IHA. Okay, so we have bite cells and Heinz cells. Simple. G6P deficiency. The fuck I said spherocytosis. Okay, I was so stupid. We don't see Heinz and bite in spherocytosis. We see Heinz and bite in G6PD, because G6PD actually, okay, step by step I'm going to tell you how it happens, right? So we have less NADPH, right? Less NADPH leads to less reduced glutathione, less increased oxidation, hemolysis, right? Then we have increased unconjugated bilirubin, and we have increased LDH, right? Lactate dehydrogenase, right? LDH, that is lactate dehydrogenase. Okay, so we have these weird oxidized hemoglobin, right? We call it oxidized hemoglobin because we have less NADPH, right? So we have these oxidized hemoglobin, right? And they come together and they make this clump. Now this clump, denatured oxidized hemoglobin, actually is called Heinz body, right? And this Heinz body later is eaten up, is taken a bite from macrophages. Which macrophage? Spleen macrophage. And then once they bite on the Heinz, we get these bite cells, right? Once we get these bite cells, right? They are not schistocytes, they are bite cells. They are eaten by the macrophage. Schistocytes are mechanically messed up. Okay, now bite cells are seen on smear. Heinz body are seen on stain. Which stain? Supravital stain. Important stuff right there. So in G6PD, we'll have a 12-year-old girl, boy, whatever. Viral induced jaundice, bite cells, Heinz, unconjugated go up, LDH goes up. G6PD, even if the NADPH is less, okay. So question can say defect in NADPH, less glutathione, pentose pathway is messed up, same disease. And I think I remember one more thing: pentose pathway enzyme, and we have a other shunt called hexomono shunt phosphate pathway. That is also same thing, okay? So remember that. So drug virus can trigger hemolysis in G6PD. Okay, so we have spirocytal Heinz body. What about Burr cell? Weird name. Burr, we have PK, the protein kinase deficiency or uremia. Okay, so now what's really happening here? Why they are called Burr cell, etc., etc. I'm gonna tell you. Okay, pyruvate kinase deficiency. We call Burr cells as echinocytes. Okay, important stuff. Echinocytes. And what really here is that PK deficiency, protein kinase deficiency, is autosomal recessive, right? So 25% of you getting it from your, I don't know, from your parents maybe. And this protein kinase we need in glucolysis. Important that RBCs do not have any sort of nucleus, so they depend on glucolysis for everything, for survival. So less protein kinase, so no ATP, less ATP. What's gonna happen to sodium potassium pumps? This Na potassium pumps gonna messed up. Na is not gonna go out. Na is gonna start accumulating inside. Na gonna call a lot of water, osmosis. Cell is gonna swell up. Hemolysis gonna happen. Okay, so hemolysis happens. And what kind of hemolysis? What do you think? Now, it's weird, even if I'm asking. Pyruvate kinase is an enzyme used in glycolysis, right? Glycolysis. They're getting messed up. Now, what do you think? Without ATP, RBC lose the membrane, right? Now, RBC lose the membrane. Now, whenever we have some sort of deformity in RBCs, we want to think about spleen. So usually normal RBCs get squeezed through the narrow splenic cords, right? Red, something on a reticular system, right? They actually what happened here is that normal RBC must squeeze through these narrow splenic cords called sinusoids, I think. And this rigid RBC in PK deficiency gets trapped inside the spleen. So splenic macrophages are like, I'm gonna eat them. So we have extravascular hemolysis. So PK deficiency, less ATP, bad RBC, a lot of edema, they get eaten up by these. So we'll have hemolytic anemia, we'll have jaundice, we'll have splenomegaly, we can have gallstone as well, because the indirect bilirubin is increasing because RBC is dying. Okay, Burr cells seen in PK deficiency uremia. What about spur cells? Spur cells we seen in liver diseases. What exactly are them? So we have these spur cells. Now they are also called acanthocytes. Now these acanthocytes are just like this. They look like this. And what happened here is that too much cholesterol inside the RBC, we call them spurcyte. Why too much cholesterol? Because liver is cooked. Once you have bad liver, once you have liver diseases, we have the ratio of cholesterol upon phospholipid goes bad, ratio is bad, so you have spur cells. And amazing thing is that spur cells, they have irregular thorny spikes, where else these Burr cells, these called echinocytes, the Burr cells, they have uniform spikes like this, but spur is like this. Okay, so important differentiation, right? Acanthocytes, we have uniform, these Burr cells, we have uniform spikes, we have uremia, pyruvate kinase, right? Now here what happens is that in spur cells, right, we have this two problems. We have liver disease and we have A beta lipoproteinemia. Now what is A beta lipoproteinemia? We have A beta lipoproteinemia means no ApoB protein. No ApoB protein means no chylomicron. No chylomicron means no VLDL, no transporter. No transporter means fat is not going to transport. If the fat is not going to transport, we're going to have fat malabsorption and bad neuro. So neuroscience, all of them lead to spur cells. Heat stroke angle. Heat stroke more than 104 Fahrenheit leads to organ failure. Which organ failure? Kidney failure and liver failure. When we have kidney failure, right? Okay, I'm gonna talk about kidney failure. Okay, what's gonna happen in kidney failure? What's gonna happen in liver failure? When we have liver failure, we'll have cholesterol upon phospholipid ratio bad. Too much cholesterol in the RBC, irregular thorny RBC, right? If we have kidney failures, right? I mean, just we have kidney failure in heat stroke. Just remember that. And we have hepatitis C that can also give us spur cell. That's important because liver failure. Schistocytes, mechanical shearing of the RBCs. So we have smear branches done, intravascular, extravascular done, one-side pancytopenia done, right? So we have hemolysis done. What about thrombocyl algorithm? Done. Inherited, acquired, done. We understand this. What about bleeding? If the patient is bleeding, what can we do? If the patient is bleeding, what kind of bleeding? Is it mucosal? Is it just upon the surface, or is it deep tissue? If it's deep tissue, usually it's clotting factor, coagulation factor, right? Not clotting. Coagulation factor, we think hemophilia. Which one? Hemophilia A, hemophilia B, kakoi. Which one? Simple. If we have deep bleeding, we think factors. If we have epistaxis petechiae, we think some sort of platelet, Glasman, V factor. It's always weird name. ITP, IgG against second B and third A protein. Third A actually goes for aggregation, and 1B actually goes for adhesion. Remember that. And 1A actually connects well with Willy Brandt factor, right? So platelet problems, ITP, von Willebrand disease, Glasman, Bernard Solier. Always look at the labs. Okay. So we're gonna look at the labs. Low platelets. Why the platelets are getting consumed? Maybe ITP. We have the IgG against platelets. Maybe we have TTP, HUS. In HUS we have kidney angle, HUS, uremia angle. In TTP we have neuro angle. Important differentiation. In DIC we have some sort of sepsis that may have caused it. In HIT we have heparin angle. Okay. In PTT is high only, we have hemophilia, heparin, von Willebrand disease, right? Because von Willebrand actually stabilizes what? Factor 8. So PTT goes up and bleeding time goes up. Both of them goes up. In heparin, so we have warfarin that goes on the extrinsic pathway, and then we have heparin that goes on the intrinsic pathway, because not intrinsic plus the common pathway, I should say, heparin, right? Because it works with antithrombin 3. It actually super activate the plate anti-AT3, right? Inhibitor, right? So heparin, got it. PT is high. What is PTT? PTT is the long pathway. 12, 11, 9, 8, 10. That is the common starting. 10, 5, 2, 1. I just remember it. 3, 7. That's the extrinsic. That's tissue factor. That's the fast. That's slow. That's the relay. That's very fast. So that is PT. That is PTT. So PTT goes up, it means extrinsic is messed up. Sorry, intrinsic is messed up. If PT is messed up, it means extrinsic is messed up. Okay. So PTT high, hemophilia, heparin, von Willebrand, right? And if PT is high only, it means 3 and 7 is messed up. It means vitamin K. Warfarin, because stops the vitamin K. Early liver disease, vitamin K, right? Factor 7 disease. Again, 3, 7. 3 is the tissue factor, 7 is the golden number of PT. Of PT and PTT both high, we have DIC because we have a mass consumption of clotting factor. We have severe liver disease because the factors are not being manufactured by the liver. We have severe vitamin K deficiency. Why? Because the patient is taking some sort of calcium bicarbonate. Maybe he's taking something. He's taking something that is ruining the vitamin K absorption from the stomach, and he's taking some sort of antibiotics that is actually ruining his intestine, because a lot of bacteria can also give us vitamin K as well, right? So get it. PTT both high, we have DIC, bleeding, clotting simultaneously. First is clotting, then is bleeding, by the way. Platelets go low, fibrinogen go low, D-dimer goes up because the plasmin is working to eat that clots, right? So PT goes up because it's getting more time. By the way, what's the normal time of PT? Normal time of PT is around 5 to 15 seconds, I think. I'm not wrong, hopefully. And PTT is around 15 to 40 seconds, I think, right? Okay, and bleeding is around 7 seconds. Okay, anything more than 7 is kind of weird. Not weird, wrong maybe. Thrombocytopenia. Why we have thrombocytopenia? Why we have less platelets? Why? It's not thrombocytosis, it's thrombocytopenia, less platelets. Why? Maybe the patient is sick or maybe he's not. Well, if the patient is sick, it means we have these TTP, HUS, DIC, HIT, heparin-induced thrombocytopenia, right? TTP pentide, right? We have MAHA, that is, MAHA is MAHA, okay? What is MAHA? MAHA is just microangiopathic hemolytic anemia. Wow, weird name. No, it's not weird. Micro means small, angiopathic means vessels, pathic means disease, path means pain, and hemolytic anemia, the RBCs are being destroyed. Now, in TTP, how MAHA happens, how this angiopathic, microangiopathic destruction of is happening. We have in TTP, we have Adam TS13 goes down due to we have deficiency. Now Adams 13 actually clears these large von Willebrand factor, right? Multimeres. Remember multimere word. Now without Adams 13, we have a lot of von Willebrand factor. Now these von Willebrand factor, they are super sticky. So without von Willebrand factor, the platelet stick excessively. A lot of adhesion is gonna happen. Platelet rich microthrombi is gonna happen. Platelet is gonna get consumed. Now the blood tries to flow through these partially blocked vessels. The RBCs get passed through these fibrins and platelet mesh, and they get mechanically sliced. Now this is called schistocytes. So this is MAHA, and we have pentard neurofever plasma. That's important. Neuro. If we have neuro, it's a TTP. If we don't have neuro, if we have HUS, remember that. Important, right? What else I can think? ITP. ITP. Well, what is ITP? ITP is just we have IgG against 2b/3a proteins. Now they are responsible for aggregation. If we have antibodies against them, we'll have no aggregation, no fibrin, no D-dimer. Important stuff, okay? Because we don't have clots, so D-dimer doesn't go up. So we have viral that can actually we can think that viral has caused, but actually usually viral is a trap, okay? So TTP goes microbleeding, not hemarthrosis. That's important. And be aware of the von Willebrand disease because we can think like this, okay? And we should know what kind of treatment we can do. We can do splenectomy, right? If after the splenectomy the patient still persists on having infection, having problems, we will have accessory spleen. And pregnant women, important. ITP usually normally seen in pregnant women. Okay, Glanzmann. So we have two syndrome. We have Bernard and Glanzmann, right? I remember that B starts, right? Bernard and Glanzmann. So G comes way after B, right? A, B comes before. So Bernard goes here, Bernard, and Glanzmann go here. So Glanzmann goes for 2B, the later proteins, and Bernard actually goes for 1B, right? So that's Bernard right there. Okay, so we have problems like this. Cool. So I'm very tired. So we have bleeding. I'm done with bleeding, I think. Deep, hemophilia, mechanical, ITP, Glanzmann, Bernard. Okay. Which lineage proliferation? We already done that. EPO. Done with that. Anticoagulation, done with that. Everything is done except these 4 little boxes. Additional algorithm. Lymph node. Painful. Why? Painful after alcohol. Hodgkin. Painless. Lymphoma. Extranodal. It's Burkitt. Okay. Waxing waning pain. Follicular. Massive elderly. CLL and SLL. Usually it's like this. You will not have acute in a child. Crab. Calcium. Renal. Anemia and bone myeloma, multiple myeloma. Okay, Rulex, we have IgG, right? Monoclonal spike, we have just IgG, and in any infection can happen. We have kind of we don't have IgM, which is amazing for complement activation, but we don't have this in this disease, so we can get messed up by any infection. So That's important. Multiple myeloma, Benz-Jones protein. These are small chain proteins, right? In the tubes of nephrons. PNH, hemolysis, thrombosis, pancytopenia, CD55, 59 absent, complement mediated, because CD55 and 59 actually are inhibitor of MAC. Transfusion reactions, if it's 10 minutes, we have ABO mismatch, very bad. If it's 2 hours, we have FNHDR. Wow, it was running on or what? So simply FNH. Wow, I got so carried away by these papers. So FNHTR, we have an FNHTR, febrile non-hemolytic transfusion reaction. So non-hemolytic means non-hemolytic. Just know that we have just fever after transfusion. We have cytokines against leukocytes of the donor. Okay, important stuff. Less than 6 hours ARDS called TRALI. We have problems in lungs. We have exudates. Exudate means inflammation goes up, capillary opens up more, then we have leakage of proteins in the lung, right? And that is TRALI. What about TACO? TACO is just cardiac or more than 6 hours, and it's usually elders who are getting transfusion every day for 6 months, and 2 years, 3 years, and then they have higher volume of the blood, and then this blood actually goes back inside the lung, and then it kind of transudate. It just seeps out of the lung because the volume is so much. That's it. Okay, I am tired very much of speaking. So have a nice day. This was all. If you guys need this kind of algorithm, I think it's very stupid algorithm. I think if you guys ever read about heme, you will understand everything. It's a very introductory type of algorithm. So have a nice day, have a nice night, I don't know. Bye bye.